Okay, so I'm Jessica, the LTCI operations lead for Victoria and South Island. Just like to take a moment to welcome you to our LTCI Learning Series event today. It's with great respect and appreciation that I'm speaking to you today from the traditional and ancestral territories of the Sauk Nation, where I feel very lucky to work and live. So just a couple of housekeeping items before we get going. Please keep yourself muted, as background noise can amplify very quickly when we have this number of participants. There are CME credits available for this event. A member of the LTCI team will email you a certificate at the should be next week for your records. At the end of the evening, we will have an evaluation, so please take a few moments and fill that in. Your feedback is very important to us. The event this evening will be recorded and posted on our website along with a copy of the slides, so just be aware of that. If you do have any questions throughout the evening, please feel free to ask away. We'll have plenty of time for Q&A at the end as well. And finally, I would like to introduce you to our presenter for this evening, Dr. Mark Lawrie. Dr. Lawrie is a family physician who has been practicing in Penticton since 1997. He initiated and completed a polypharmacy reduction project. You don't mind keeping yourself muted there, please? Whoever's talking.
I have myself on my phone.
Sunita, can you mute them, please? Dr. Lloyd worked extensively with Share BC around polypharmacy reduction and gave presentations all across the province. He has collaborated on the Penticton Regional Hospital Polypharmacy Reduction Project and incorporated his knowledge into the care of his cohort of long-term care residents in Penticton. Dr. Lawrie likes to focus on practical ideas, working through challenges, and building confidence and competency. So thank you again, Dr. Lawrie, for speaking to our group today. Just before I hand it off to him, just to note that tonight we will be using Slido for engagement. So if you want to go through, you can do that through your phone, or you can do that through your desktop. There should be a link in the chat with a ID that you can follow. Over to you, Dr. Lawrie.
All right, thank you very much, Jessica. And thank you to Sunita, who's the tech person in the background. Can anyone, hopefully people can hear me. So is it okay, Jessica? We're live here? Okay.
Yep.
Well, thank you for having me back. That's why the talk is called Medication Reduction in Long-Term Care 2.0. We had a talk, I think last year about starting this kind of discussion. So yeah, if anybody can mute themselves, that would be great while we're talking. So my topic today is medication reduction in long-term care. As Jessica said, I've had a number of years of experience in this, had some chances to fine-tune a message, and hopefully today, for those of you who attended last time, this is a reworked message with some new ideas, and that's my intention. So we're talking about deprescribing. Basically, that's the word I think that most of us are familiar with, but medication management as a general rule is what we're going to be getting into. Can we have next slide, please? So I have no disclosures. Next slide, please. So let's start off with Slido. If people can be familiar with this, this is a good way to just see who's here tonight and what your discipline is. So if you could enter in Slido your discipline, it would help us decide, a little bit about the form of the talk and who the audience is and how we can get you guys to integrate together, which will be coming up in our breakout sessions. So if anybody could just enter what position you have in the healthcare team in long-term care, it'll just give us an idea of who's here. The more of you that are in a given field, the larger the wording is. So it gives me an idea. I think there's about 26 of us tonight. Okay. I was hoping to see some pharmacists. I don't see them yet. And possibly some RNs. Occasionally there'll be a specialist interested in this. Okay. All right. Well, what I have to say tonight will certainly be applicable to all these groups and all of you members of the healthcare team. So it's getting bigger. Good. Okay. Excellent. Okay. What is a CNL? Okay. All right, a lot of
People
LPNs here.
later.
Okay, excellent, excellent. All right. Well, it's looking like we have most of the members of the team that I would expect to be involved in this, and so that's good. And hopefully we'll come away from this from some shared experiences and some good topics for all of you. Excellent. All right. Excellent. So for tonight's learning objectives, as we require for your main pro credits, I've decided we should have three. And you'll get an idea of this theme as we go along that I'm going to really try to improve motivation and knowledge around deprescribing in long-term care. We could expand this to all facets of care, but let's stick to the frail elderly and long-term care. So first of all, I'd like to see whether each of you could commit to at least 2 changes to improve your deprescribing. And we'll go through what some of those may look like, and so that you can come away with something that you can put your hands on and write down for yourself. Secondly, describe problem-based deprescribing and begin practicing this. This is a slightly new way to look at deprescribing and the problems that our long-term care patients have. And it's a good way to kind of get your feet wet in how you approach deprescribing and medication reduction. And we'll go through what that is and how it looks for you. And then finally, and this is a topic I always tend to focus on, which is how do we improve our patient-centered conversations as we try to promote effective and safe deprescribing. These are landmines that we learn to avoid, and we'll go through some options for you to improve what you're doing now and give better care to your long-term care patients. Next slide, please. So what I intend to do tonight was as I said, have you connect with the needs you have around this topic, connect with each other, have some curiosity about some new stuff, build some teamwork here, and hopefully there'll be some transdisciplinary talk in your groups that are coming up to promote that. And the idea is to promote this in long-term care and work together and maybe even do some problem solving tonight. So hopefully increase your motivation and give you some new approaches that you may not have considered to move things forward. My intention is to encourage action and change in yourselves and building good habits. So next slide, please. So I just got a couple slides, just a general overview of the issue. So we're really talking in this field of medication overuse and polypharmacy, which is a growing worldwide problem. And it's associated with harms, often questionable benefits, and requires everyone to do their part to improve. And we'll focus on this team approach tonight. So how did we get here, and what can we do to benefit our long-term care patients? Well, basically we got here by doing good medicine most of the time. We treated diseases as they came along, we piled on new medications, and we kept going. And these patients have lived to be ripe old ages, but they're now frail, and their metabolism and their ability to handle things has decreased. And so we've left with a cohort of patients in long-term care who have benefited some degree from good medical management, but now at the point where these medications are frequently making them ill and harming them. And so we've reached this point where we need to make some changes. Next slide, please. First, a couple of definitions, and everybody's probably familiar, but I keep them simple and would say polypharmacy, which refer to as the use of medications that result in more harm than benefit, now or in the future. There's a lot of uncertainty in this field, so I want you to be detectives as we go along and assume that problems are there, even if they're not always visible. Next slide, please. So the deprescribing itself, I want you to think of as not just reducing medication numbers, but it's a process that results in tapering or stopping medications, which are frequently inappropriate, and we can decide what that means, to minimize polypharmacy and improve outcomes. We're trying to do some benefit for our patients. Okay, next slide, please. So first thing I'd like you to do is have a breakout session. Sunita will randomly put you in groups of probably 5 or 6 people, and we're going to hopefully have a mix of doctors and nurses and pharmacists and RNs and whatnot. I want you to maybe put aside any sense of hierarchy and work as a team. Share maybe some uncertainties. Hopefully that's useful, and try to identify, first of all, what barriers that you or your health team face in your facility or wherever you work to promote and deprescribing and reduce medication. So what is holding you guys back? Okay. Secondly, after you kind of had an idea what the issues are personally or in your teams, discuss maybe some ways you could overcome those or strategies that might work and might be practical for you to overcome the barriers. So I want you to take some time. You have about 15 minutes. I want each of you in the groups hopefully to provide some input. And if one of you, okay, are people signed in again? Looks like we're just coming back. Okay.
Slowly joining back in the next sort of 50 seconds.
Okay, good.
Oh, on that iPad.
So Jessica, all the questions are coming in chat, right? Okay. All right, are we just about ready to go? Okay. Jessica, we're ready to go now?
Yep, go for it. There might be a couple
Okay.
people straggling, but yep.
Okay, well, thank you, participants. I was able to join two groups and having a look at what you were talking about, and I think what I was getting at is trying to identify specific barriers. One that I heard about is the communication barrier, and I've heard that there are some facilities or places that are very successful in maintaining a cultural focus on this, and certainly incorporating deprescribing or polypharmacy reduction seamlessly into long-term care is really a goal. It shouldn't be something we add on. It should be part of our culture. I think that was a really good point someone made. Does anyone want to enter any of their barriers or solutions, but certainly start with barriers? I was thinking, the barriers tend to be personal or group related. There's a culture of using medications in North America and around the world, a culture of treating some of our frail elderly as we would younger, less frail, and this is what's happened with polypharmacy. If we get a few ideas, that would be nice. Otherwise, I can move on to describe more. I'll just wait a minute if anybody wants to contribute. Exactly. I'll address that, but you're right. Our paradigm in long-term care has become one of a palliative approach. And I think that makes deprescribing easier, and we can talk about that briefly. I have a slide on that. I think expectations are always fraught with some potential problems, but they usually are a reflection of what our society in general expects about our medical care. So we have to facilitate a change in perception there. Okay, there doesn't seem to be too many more. Do we have any solutions on the next slide or strategies? Anyone have any strategies, say around communication? Any particular strategies that you use to deal with the uncertainties and the culture of continuing medications? Anyone have a few breakthrough ideas about that? Oh, looks like we've got a few people. This is something I'm always looking for and trying to incorporate in my practice so that it'll work. That's interesting. Contract, I guess, to specifically indicate that medication review and reduction is part of excellent long-term care. I guess that's what you're looking at. That's interesting. I think a discussion would have to always be held in regardless for that kind of thing. And it's never a one-time thing, is it? It's always an ongoing set of discussions. Yeah, that's good. Team meetings, excellent. I agree. Without the help of my care staff, I'm in the dark with a lot of my needs. Regular meetings, absolutely. I think involving pharmacy is often overlooked, but pharmacists only have a piece of the puzzle. And as care staff and family physicians, we need to put together the functional problem list, which we'll go over to really make a full picture. Pharmacists are excellent at the nuts and bolts of deprescribing, but there's a much more patient-centered approach that we need to make sure we always adhere to. Right, okay. Okay, all right, more communication. Yeah, exactly. So what I'm getting at is a lot of teamwork, communication, and facilitating what can be a challenging, but also very rewarding phase in a person's life. Okay, so let's go to the next slide. Okay, yeah, any other questions? Let's just move on. Jessica, and we can incorporate questions later. I want to pick up the speed of it and give you some more information, and then I'll get you to look at the case, which maybe we'll put things together. So the big picture, as someone alluded to, is we've now taken a long-term care approach that involves really seeing patients in their final months or years of life in a palliative paradigm. And what does it look like? Each facility is different, but I think that has to be part of the culture, as someone alluded to. What does palliative care look like? It certainly isn't disease-based. It's problem-based and patient-centered with a lot of shared care decisions. So does this help us? I think so. I think it makes the paradigm, if we're aware of it, it makes a lot of what we do in medicine not necessary anymore. And this is a transition for physicians and anyone looking after these people to appreciate this. And so families are no different, and they need to be consulted and worked with as their loved ones transition to a new phase of their lives. So next step.
Looks like we've got a question from Dr.
Okay,
Brooks.
excellent. Go ahead.
How do you feel about the word palliative?
I think for me it means maybe different than other things, and I think people need a description. For me, it's a very patient-centered, conversation-based, goal setting, practical approaches, looking at values and preferences. So I find it I really like it. I like palliative care for that reason, because it involves those. It gets me back to what a physician and a nurse and a care aide can do. I think if it's defined properly, then people are not necessarily afraid of it.
How will families respond when they see the palliative care unit where people are actively dying versus the so-called palliative paradigm you're invoking, as compared to, say, late life care?
Well, I guess you can pick whatever term you want, David. I mean, late life care is what we're talking about, I guess, eh?
Why not call it the late life care approach?
I haven't determined one way or another. My sense is, though, that in some of the papers I've read in terms of approach, we should be using. They use the word palliative, so I use that loosely. You can choose whatever works well. I mean, I don't start with the palliative. I end with it, so we can call it palliative, but I start with a patient-centered, family-based questions. And then, okay, so we do agree this person's in their final months or years. We tend to call that palliative, and this is how we approach it. So I think if you bring it at the end and you've made the agreement, I think that's much more acceptable.
Thank you.
Okay, thank you for the question. We all can get hung up on words, and they have meanings, and we need to understand each other, what we're talking about. So we think we need, as deprescribers or people, we think we know what we should do, but we don't know how to do it sometimes. And so the next slides are heavy in information, but I'm going to have 2 or 3 nuggets I want you to hang on to for the rest of your careers, if you don't already have them. I think they're really useful. So we're going to get some ideas that maybe we can use with our health teams to build some more motivation, confidence, and success. So when we look at our understanding of any topic, we tend to have some things we know, and studies have shown that it's actually much more that we don't know about any given topic you can think of. And particularly in the field of medicine, there's a lot we don't know, okay? So what we do know is sometimes we know family wishes, and if we don't, we get into trouble. We know that we don't have a lot of time. We know some of the details. It's often shady in these patients. We have a bit of a problem list, which is usually a list of diagnoses. And we know how we feel about drugs, or maybe we haven't questioned it, but we do often rely on drugs. We're grown up as prescribers on this. Patients and families feel drugs keep them alive. We have some sense of that, and there's often a pressure to treat diagnosis as people go along. We know something about palliative care, but getting it going is often a bit of a challenge for someone who's not actively dying. What we don't know sometimes is, once again, the family and patient wishes. A big problem that if we're not clear about will lead us into numerous problems. Some of you may have faced those. I certainly have, and we can discuss how to sort those. We don't necessarily know what polypharmacy does to our patients. We don't necessarily see the harms. They're not always visible. We don't always know the drug benefits. Often they're very minimal. We don't always have an efficient process. We don't know the risk necessarily, what to expect, and we're worried about that. We may or may not have a good health team support that needs education to move along with us, because if we're going to implement new ideas, they're going to have to be along with us, not following and dealing with our disasters. So we need to be cognizant of that. And we don't always know what deprescribing does for people. I can tell you at the latest international conference that I attended virtually for the first time, the first World Conference on Deprescribing, the evidence of positive outcome and benefit is lacking. Okay, it's very lacking for deprescribing. What is apparent that for the majority of patients who are deprescribed, there is no harm whatsoever. So that is in fact the benefit if you consider the results of getting medication. So there is benefit, and I also want you to think that to continue a medication is a decision. To stop a medication is a decision, and let us not be people who by default agree to continue medications without some reflection that I'll get into. Next slide, please. So we face a lot of issues. For a second, just do this little exercise if you like. How would you imagine a person deprescribing for you or a loved one when the time comes? What would your preferences be? Okay. I think if you can put yourself into there, because it'd be very difficult as a cognitively impaired adult. But certainly you would want conversations. You would want to be respected. You want to be treated with dignity. You'd want to know someone had a sense of what we're doing and a teamwork. And that if something went wrong, your adverse effect would be dealt with. What would your preferences be? I think it's not that you need to put yourself there, but I think that'll give you a lot of the ideas of how the palliative care approach and deprescribing should go for people. Next slide, please. So I use this term mindset. What I've tried to incorporate into my frail elderly assessments and treatment is I just try to think about medications all the time, and I think about polypharmacy, and I think about their problems, and I try to keep it first on my list of differential diagnosis. I'll put a polypharmacy as a problem. I'll put it in there. So my concern is you can't change what you don't think about. So if we can put polypharmacy, deprescribing to the forefront of our brains for any clinical session, particularly long-term care, we can engage ourselves in what we already know. So there are many indications to assess for deprescribing, and I'll go over some of those next with a couple of pearls. Next slide, please. So here are my 3 pearls coming up. Everybody can wake up again. What I'm saying is the next 3 slides need to be noted and remembered. I think they're pretty good, and these are 3 really important points. If we never forget, if we remember these from the talk, I think we're going to be all further ahead. Next slide, please. The first one is the absolute number of medications is the single most important factor that predicts adverse drug effect reactions and harms. Whether it's a vitamin, whether it's a laxative, the number does seem to be the issue. The interactions, the failures to give it properly, the issues, it's number, okay? Nobody can give you the clear number, but more than 5 seems to be causing some literature alarms that numbers go up. We see the benefits every day. We kind of over assume the benefits are there, but we don't see the harms. And we need to realize that these are there regardless of whether they're seen or not. And we need to focus that this number is important. Next slide, please. Second point is, and this is maybe even more important, any new symptom a patient experiences in long-term care should be suspected to be a possible adverse drug reaction, any symptom, and a potential opportunity to deprescribe. So whether an LPN notices someone falls, whether there's an increased constipation, you're asked to provide laxative, have a look at it. Have a holistic look. Think of polypharmacy first. We'll go over that. And always remember that most of the time you'll be right. In fact, it's so often in long-term care that you can hardly go wrong by assuming this. Next slide, please. Finally, here's a question I've come up with that I think is the most important one to ask for you as prescribers or even as care people in the team. If you're prescribing or deprescribing, you just ask yourself, with all I know about this patient in this condition at this time, would I or should I start this medication at this dose now? In other words, it allows you in blue to say, no, that's not a good medication now. I think that should go. Or conversely, when we prescribe, as we should in long-term care for legitimate reasons, should I start this medication for all these reasons? This gives you a pause, and you can even do this individually as you go down the list or assess the medications a different way we'll get to. But this is a very powerful way for me to take a break, take a couple breaths, and really know that I've understood the patient and the complexity, which is great. And have I considered the proper medication at the proper dose? And now, maybe I think they're going to be dead in 3 months. Am I going to really start this drug now? So it's very patient focused, very patient centered, and allows you to distill all your information and help you make a decision. Next step, please. Next slide. So here's an article which will be sent from the Canadian Family Physician in 2019. It introduced the term problem-based deprescribing, which is how I've kind of fallen into my deprescribing over the years. But basically what it is look at the patient's current functional issues. Are they falling? Are they constipated? Are they incontinent? That's what that person's living with. That's what they deal with every day. That's affecting their quality of life. And that's what palliative care should focus on. Unfortunately, many of those problems are drug-related or drug-induced or results of our failure to recognize cascading symptoms. So it allows us, if we use this approach, to say, how is this person doing now? What is actually going on? If someone says they have Parkinson's, that tells me nothing about their current functional status. I need to know, are they able to get up and walk? Are they bedridden? I'm going to alter my treatment based on that greatly. So a diagnosis list tells me almost nothing. So I use that, but I tend to focus on give me the list of their current problems. And I find that that's largely where a lot of deprescribing can be used to benefit. And it allows you to discuss things with families about what are we going to deal with first? Mom's falling, dad's incontinent. Let's have a look. The geriatric syndromes you may be aware of are things like depression, delirium, dementia. There are many geriatric syndromes that we're familiar with that we assume are just from getting frail and old. No, a lot of them are actually exacerbated or even caused by our medications. So let's not just write them off. Let's go wholeheartedly into this problem-based, draw up your list, and then we can attack it. There are ways to deal with it, including tools and guidelines, and they have a rule. But unless you do this, I think you're not going to legitimately be able to engage these. These are not patient-centered in the sense that they're not patient-specific. They will help you change a particular med that you already decide could be to blame or should be stopped. But to actually get to them, you need to do this approach. So I think this is really cool. I think if you look at this, it'll go over some of my points that I just went on about any symptom being possibly drug-related. And it gives you this idea that start looking at your patients from this lens. This is what they deal with every single day. This is what your staff deal with every single day. The constipation, the incontinence, the falling. How can we improve that? Okay. Next slide. Okay, I'm almost at the end of all this heavy information. Then we'll get into a case about a lady named Daisy. So if we look at what you actually do once you're deprescribing, um, you basically first need to know what is this person's condition, and that can include drugs, problem list, reasons they were put on them, their diagnosis. That's all important information. But then you have to say, what's the picture? Can I paint a picture in my head about what this person looks and is doing that will then guide me to better palliation and drug assessment? Some drugs will have more risk and you can become familiar with them. I'm not going to go heavy on drug specifics, but we can do that in the questions. There is a way to rank them. Like if you don't know which one to start with, there's a way to do this. And we'll go over that next very briefly. Won't spend a lot of time on it, but it makes sense. And then you need to make an idea. What do we do first here? Let's get started, make a plan, and how do I communicate that plan? And when do I involve all the stakeholders, including family? Next step. So you can review all these details, but this is a defined process that tends to work well. This is a guy in Australia named Ian Scott who's recognized as having a good approach, and so you can always look this up. Next step. Next slide. So basically what it is, we're assessing the person. We're going to look at the need to deprescribe or consider that. We're going to make a plan, do some priorities, and then we're going to go ahead and do it. Ranking is just how you figure out which ones to stop first. So the bad drugs, the drugs you're making, you got them on for other drugs. We'll go over what cascades are in a minute. Are first, if they're maybe harmful now or future, because they're frail, their metabolism is so different. They don't handle these drugs well. So assume there's harm. Just be a detective, assume there's harm and check it out. Are you treating them for something that no longer needs to be treated? Well, the only way you're going to find out is to taper them off or stop them. And are you using a preventive drug in a palliative care setting, which is really not a good idea. So, it makes sense, but if someone says, well, I just don't know which one to try first, go ahead and run it through the ranking. I often will actually prescribe several medications at once. I find it's, once you get a level of comfort and your staff and your facility and your patients and your families are comfortable, then some of the work is done. But if you do it correctly, you don't have to go and repeat yourself every time. Next slide. Any questions so far? I mean, it's a lot of information, so I'm just going to go in the chat and see. Someone mentioned MedStopper. Absolutely. It's a tool developed, I think, through the Therapeutic Initiative Group and Dr. McCormick. It is kind of cool. It gives you red, orange, and green markings for drugs. It does. I find the main thing that MedStopper does, and anybody can look it up, it's free, and you can build your med lists and you can look, is it tells you how to taper things. And that's a really good source for tapering. A lot of us are worried about that. I can briefly say that for tapering, I generally only do it for psychotropic medications, anxieties, antidepressants, antipsychotics, and cardiac meds. I don't taper a lot of other stuff, but those are important ones. Every 2 weeks, 25 to 50%, do it in 4 to 6 weeks, you'll succeed most of the time. Any other issues here? Yeah, there's some issues here. Remember, is okay, more communication. So we'll compile these ideas in case we miss something that's kind of critical or interesting, or have something maybe to help someone with, and we'll get some feedback to you. Okay, does anyone have any other questions about the idea of just getting that mindset going, always looking at medications and polypharmacy when there's a clinical change of any kind, not assuming that those symptoms are just from the getting old into long-term care, always thinking that it could be meds that are doing it, and always trying to reduce the numbers because the absolute number is so important. And don't add something just because, well, yeah, okay, vitamin D sounds like a good idea. I mean, I don't do that anymore. I've overcome the anxiety of having the dietitian look at me and think I'm on Mars, and I go, okay, no, there's no evidence. So, I mean, once you get over this, maybe it requires education, but I think I look at that absolute number and I go, I'm knocking vitamin D and calcium off right now. That's 2. Oh, and by the way, she's no longer constipated. Isn't that great? Okay. Anybody have any ideas about what we're talking about? Any other questions? I think problem-based approach is the way to go for me. in our next case, you'll see some problems, and you can maybe look at it from that way. Okay. Doesn't look like we've got a very, I don't know if this crowd is low on food or low on sugar or low on liquids, but I appreciate you listening. If you come up with things as we go along, please put them in chat. Next slide.
We've got a hand up from David Brooke.
Okay, David, not you again. Okay,
Sorry.
that's all right.
You shouldn't have invited me if you didn't want to hear a lot. I think you made an excellent point. I think to some extent we are slaves of numbers and measurements in late life care. Blood. I got one today of a blood pressure of 190 over 80, and the nurse was concerned about that. It was a single reading. And I replied in the usual way: a single reading does not hypertension make sclerotic arteries, etc. This isn't a 95-year-old woman. So, no need to treat the fact we've been involved in deprescribing programs for antihypertensives in the hopes of reducing falls with mixed results. But the point I wanted to make was, when nursing standards demand that they contact the physician when a PO2 goes down to, a certain figure, or blood sugar goes over 20, or blood pressure goes over 160, 180. There's an opportunity there, I think, to, as you say, educate and also absolve, I think, nursing, but they in turn need the direction from their masters. And I don't know that licensing, for example, is a very good master. I don't know that the RNABC is a very good master. CPSO, or even our college.
Yeah, it's an excellent point, and how we interface with our staff is very important, as a lot of these issues are recurring. And I know in your 3,400 residential care patients in your section, with, as I got from Jessica, about 100 doctors and 37 facilities. It's a hell of a diverse community, and I think I've tried to do incremental work with that, but I agree some kind of sensible palliative standards would be well taken, and allow our staff to focus more on the palliative aspect and less on numbers and blood sugars and things. Yeah, good. Next slide. So one of the topics that I go over, and this is a simple model I devised quite some time ago, is that conversations are really, really important in palliative care, because first of all, if they go into long-term care, they've been there, that's a huge transition, and I think people need to acknowledge what they're leaving behind and what they're heading towards, and families and loved ones and patients are often kind of bewildered. The care that they receive there, it will and should be different. It shouldn't be disease-based. It should be patient care centered, and values and preferences, as it should in all of medicine, but it becomes much more relevant in long-term care. And someone is often speaking for the other person. So when things are kind of at the near end, caregivers or family members assume the role of gatekeepers, which they are not often prepared for. And they bring in their own assumptions about their own health and their care. And so we need to be aware of that. How do we go from their emotional situation when we're trying to say, hey, I'm a deprescriber, and this is so. The only way we do it is we have to get back on the same page. So we connect heart to heart. We connect with understanding and perceptions and expectations. And yes, we may have to talk ourselves down from the value of medicines that we promoted all our lives to these patients. Yes, we may have to back off and say, that medication has a best before date of 5 years ago. Your mom may have a couple of years to go. It's over for that medication. And that's good care, Susie or John or Mary or whatever. That's good care for your mom. And then once you kind of have a share of the land and where people are, you can go back very quickly to a problem-based approach. And patients and family at that point will often quite handily say, okay, you're going to do this, this, and this because of that, and that sounds reasonable. Let me know if something goes wrong. Can I continue the process if you like? Sure. If something changes, I'm going to review because it might be medications again. So, and then what happens is if you slip and there's suddenly resistance, which we all know what it feels like, what it feels like is we're trying to convince somebody of something. Okay. And when it feels like you're trying to convince somebody, you don't understand enough. So you have to go back here. You have to go back. Tell me, it seems hard for you. You're going to potentially lose your mom, and I know you've looked after her. How does that feel? And what do you think would be the best for her in this, regardless of medication? So, when you lose people, when you feel like you're working, when you're wrestling and you're not dancing, go back to what's really going on. What don't you understand about the situation? When you understand it, and there's some agreement, you can go back into your problem solving mode, which you love to be in, right? This is a love because I know what to do here. Here it's a bit mushy, but in fact it isn't. If it's a wonderful thing to come to some agreement and help that caregiver transition to this person's new phase in life. I think it's important in all palliative care, and giving them permission to say, yeah, no, it's really not going to be great. So I think conversations are the number one thing that mess people up. I know I can use probably Margaret Manville as an example, a very capable physician. And she said recently she had a full discussion about deprescribing with a family and stopped some medication on a patient, which within 4 days, the patient had what could be perceived as a complication of that. The patient died shortly after. Uh, Margaret said without that conversation, it would have been extremely difficult to recover um, for her and the family. And having that preemptive discussion with all the uncertainty that's involved and acknowledging this is an uncertain area. People will acknowledge uncertainty if you let them and you make it clear. And then she said, that was it was really fantastic in the end that it was tolerable, and that conversation at the right time made a difference. Next slide, please. So in terms of, I'm just going to have a quick peek at my stopwatch here. In terms of what we're talking about conversations, I'm looking at helpful ones, listening conversations, inquiring conversations, curious conversations, where you say, what was your mom like? What's she like now? What do you think's ahead? When do you do it? Well, you do it when they're admitted, because they'll often be railroaded, in fact, from home to the hospital, develop a complication, have all these meds added, and everybody's in an uproar, and then they land in long-term care, and then suddenly people are going to start talking about the end of life if they haven't already, which they don't often in acute care. It's a hell of a shock. So there's going to be a lot of initial listening and understanding. Whenever something changes with the patient and you think it could require a significant deprescribing, why? Well, it saves you a lot of time. It avoids some of those landmines that blow up if you don't do them. It's very reassuring to people to know that you understand their point of view, and you're agreeing with their wishes. And you know what? If someone is really resistant, I'm not going to lose sleep over it. I'm not going to work harder than they are to provide the care. I'm going to give advice. I'm going to try to understand what's going on. But if I hit resistance, I can move on for a while. This isn't the end of the world if someone doesn't want to stop a certain medication. But often they will come back after a couple of discussions and go, I think maybe it's time. So don't overwork yourself in this, but take the time initially, and whenever something changes, before you jump on a whole bunch of med changes. If you're going to add something, which we often do, maybe have a quick conversation about, we got to do this for your mom. She's just so agitated or whatever. How do you do it? It's often over the phone for me, but ideally if you have a chance at the bedside or with the family there, it's great. And what do you talk about? You talk about just that. What are your feelings, preferences? What do you think's ahead? What can we do for you now? The medications don't have a lot of effect anymore. In fact, these are probably somewhat harmful for your mom or dad. So let's look at what we can do. In my opinion, in my experience, this is a good idea. And what you do in a difficult, like I said, roll with it. Roll with it. It's not your job to change the world. It's your job to be a listening, compassionate physician or care aide or RN or director. And if something is, maybe you just don't understand, or that person's just not ready. And you have to limit your time. You don't have endless time, so we have to be efficient. So when you've done your best, sometimes you just have to back off or have a conference, as someone said. Conferences are sometimes good because they add weight to your side, but they can be intimidating. And as long as people are having a very simple message of listening and understanding, they can really help too. So get everyone on a page, especially if you're dealing with someone who's talking to different members of the team and creating issues. Next slide. Okay, so we've looked at Daisy before, and I want you to now head into a bit of a breakout. We're going to look at this. The person we were talking about, Daisy, has had a fall, and you or your team considers what to do. Here's her med list. Once again, not totally unreasonable. She's lost her balance and can't recall any faintness. She's had several falls. She's constipation, incontinence, poor memory, and is occasionally disoriented. Her appetite's not great, and she's had some pain and stiffness for a few weeks, which is unusual for her. She's bruised, but otherwise okay. I want you to start looking at this in terms of, I haven't given you all her diagnosis. I want you to look at the meds, and I want to look at the problem list and look at all these issues and how they might interplay with that med list. Next slide, please. Okay, so briefly before you break out again, and Sunita will do this, and I want all people to kind of have a look at this no matter whether you're a prescriber or not, or a pharmacist or not. So we need to think like curious and suspicious detectives. The crime is polypharmacy, and the drugs are suspects, alone are gangs. Gangs refer to the issues that arrive with multiple medications, okay? It's not that they're all bad actors, but you know, we need to be suspicious because the harm is often hidden. The benefit is often overstated. So how could Daisy's medications have contributed to her fall? Basically, something's happened. I'm going to assume it's the medications. Are there any other harms that we've overlooked? Anything else could be going. Can you see any drug cascades, which is when you prescribe a drug to treat the side effect of another drug? These are very common. You need a little information about certain drug effects, but it's available from your pharmacist and other things to understand what those are. Can you look at a problem that's based on problem deprescribing? What are your priorities for this time, given what you know about Daisy and what her current major problem might be? Can anyone else contribute to your understanding? Do you ignore it and let things settle down and just tell them, oh, thank God, maybe we're going to restrain her and that's it? What would be your approach? And what does her daughter think? And why? And also, I gave you a little tidbit in there. Why is Daisy more stiff lately? You always have to be aware that something new may pop up for which you can provide comfort and treatment. Next slide. So I'm going to get you to break out for 15 minutes. I want you to think about resistance. Daisy's daughter, in fact, wants everything done. What else would you need to deprescribe? I haven't given you lots of information. I haven't given you vitals. I haven't given you numbers. I haven't given you creatinine clearance or blood sugars. I haven't given you any of that. Might you need some of that? You might want to think about it when you're deprescribing. And what's most important to start with? Would you taper something? Would you stop it? Have a look at the meds. Try to make a sense of where you would attack this problem and see whether there's anything obvious. And have you actually checked from the information sources you need? What are your targets? What are you trying to achieve with Daisy? And are there any barriers? And try the problem-based deprescribing approach as a way to just look at it. And don't think of her as a bunch of diagnoses. Think of her as a person who's got some significant problems. Next slide. So this can be brought into your breakout group, her list and her problems. And I want you to think about it and think about what those questions. And then I think, can we just have a look at the next slide? I'm just not sure if we want to look at that yet. Go ahead. Yeah, okay, just go back to that slide. So if people can break out again, we'll randomly break you out. I want you to try to participate and think of it if you're a care aide or an RN, think about the constipation. Maybe you haven't had the mindset that this is medication related. In Daisy's case, people who know more about the medication can let you know it certainly could be. Her incontinence, which we've treated in a certain way, could in fact be medication related. And then we all need to be aware of that so that we don't just put pads on or blindly prescribe or give them the medications you know you'd rather not give them. What else is going on? When are these episodes happening? Okay. So we'll do the breakout session there. I think if people could break out and have a look at those, the problem list and the medications, and see if you have a sense from your own current level of knowledge and what we're talking about, how you would go about addressing this and what else you need to know to do that. And think about why she might be stiff. Okay? So Jessica, Sunita, you're breaking them out, right? Okay, good.
Happening there.
Okay, all right. Okay,
Yep, everyone's back. It looks like we did have some technical difficulties. Some people were discussing different cases because we had some issues with the Word document, but hopefully there was robust conversation nonetheless.
yes, excellent. Okay, so let's see, what do we got here? Let's do the next slide. And okay, so what I'm going to look at, we're going to do a Slido poll just as a quick idea of what your motivation to continue working towards this is on a scale of 1 to 4, where 4 is just it's your mission in life, and 1 is you couldn't be bothered. If you can enter something there, we'll just try to maybe build a sense of how the group's feeling. While you're doing that, I'd like to thank you for what is for me a very difficult way to give a talk. I do prefer in-person stuff and the give and take. I appreciate some of these. I'm not sure the breakout group worked as well as I wanted, but I hope it stimulated some discussion amongst different disciplines and people. Oh, geez, looks like some people are interested. Okay, I guess that's it. I don't know how many put in that. I appreciate that. I think I'm reading a book on habits, and I mention it because it's kind of cool. It's called Atomic Habits, and they basically said there's 3 things that were studied to see whether people could make a change. The one was they had to look at themselves a little differently, and in this case, I'm asking you to think of yourself as members of a team of deprescribers or medication reducers or medications. I'm asking you to kind of take that identity on. They did this with a group of people, and they said, okay, here's we're going to give you this information. Then they also give them a pep talk and said, you know, you're great, you can do this. When they compared the people with the information like we've given you tonight and the pep talk like I'm trying to do, it made almost no difference. Almost no difference, which is really discouraging. But the key point was that when people were able to take what they learned and how they were feeling and make a statement of commitment to themselves, that the success rate went through the roof. Okay, so what I'm asking you to do is to consider what kind of a habit change you could make around deprescribing, and we'll go over a couple of points about that might be basically what it is when this happens, I will do this. And we're going to give you a couple examples of deprescribing options. We don't really have time to go into the second case, but I think it was looked at by some people. Next slide. So it looks like there's people, motivated. Next slide. On the okay. Does anyone? I mean, it's been hard to get the questions forward, and I appreciate you listening. Does anybody have any burning questions that we should be looking at? If anybody wants to send things later, I'm more than happy to review and send stuff back to Jessica for distributing. I've loaded you up with a lot of information, and I know it's the time of day when you're probably hungry, so I do appreciate your attention. I wanted to make the talk as interactive as possible, which is a challenge. Okay, let's go to the, and in the interest of time, let's go to the next slide. Okay, basically, Stanley Falls, pun intended, was intended to just reinforce for you the idea of problem-based deprescribing and looking at the diagnosis, but looking at what was really going on with Stanley. And whenever you had a change, you had an opportunity to deprescribe, to assess polypharmacy. use those opportunities. You will make a great deal of good. Not everybody will review the same medications the same way. People will miss things. Something that came out from the group, what I was thinking about is, particularly when talking about the pharmacist who was doing an excellent job, is that we need to remember that this is a moving target. Patients are not the same as they were a month ago, 6 months ago. The medications may stay the same, but this person's tolerance, their ability to deal with them, metabolize them, is changing by the day. And so medications that worked before or were useful and don't seem to be causing a problem may in fact be causing problems. So the idea is we should be eliminating as many of the non-essential medications as possible, getting those numbers down, and if doing no harm, then we've done some benefit. And in fact, many of our symptoms in these patients may improve. So this point was something's changed, have a look, don't just jump on an antibiotic, figure out what else is going on. And maybe Stanley hasn't had a review for a while, and he's changed in the last 3 months between these med conferences, and it's time to do something. Okay, next slide. It's going to get right to the end. So basically, I want you to think, how has your understanding has changed, and what barriers are you facing with Stanley? Are there time issues, knowledge, tools, conversation, support? Hopefully the conversations have been clarified a bit, and what to do when you get resistance. If we need information on the drug effects, the pharmacists and clinical pharmacists are helpful. There's some tools such as MedStopper. Shared Care BC has some great videos on conversations if anyone's interested, with Trevor Jans from the Kootenays. Great conversations on dealing with the difficult topics. There's a treasure trove of stuff to go with here. And basically all these medications theoretically could be discontinued in both Stanley and Daisy to their benefit. There's many things like drug cascades and inappropriate dosing and the wrong meds. Next slide. So I wanted to focus less on the particular drugs and less on how you would go about encouraging your team, encouraging your families and your patients to accept this. So I'm trying to get at the end here this commitment from you to yourselves. You have a part to play, all of you, in reducing medications. Anytime you notice a problem with a patient, look at the medications as possible causes. And the caveat is, even if you don't notice a problem, because generally it will be there, it's hidden, and you have to assume that lower medications will be better for patients. You're in a perfect environment to experiment if you like. You can reduce meds, you have 24-hour follow-up, it's safe, it's effective, and in most cases you'll never have to reverse course. But if you don't do the conversations correctly and support your team, you will screw up and there will be problems. And in fact, they're not always screw-ups, they're just acknowledgement that maybe something should be restarted, that you were given good care. So I want you to think about an intention statement for yourself, and hopefully you can write something down, because I think it's important. And as I said, this study on habit change has proven that if you don't commit to yourself, it doesn't happen. So I wrote as an example, when something occurs with a long-term care patient, I will review medications as a first step. You could decide to use that, you could use anything else. Basically, when any new change happens, you could figure it out when a fall, when constipation occurs, you're going to commit to reviewing medications, okay? Maybe you need a specific case. Or you could say something, when this occurs with a long-term patient, I will have a conversation with so-and-so. For an example, just a family member or RN, or what kind of conversation, a useful, a caring, So think about what you could do, a situation, and what your response would be as the deprescriber or medication reducer that you all, I think, are maybe understanding is important. So if you can write that down, I know it's a simple thing, but it has been shown to be something, if you refer to in the next week or two, you'll probably come up with the situation you write down, put something in that may be a problem for you and that you could solve by a medication review or a conversation. And hopefully that will then initiate some of this habit change that we're looking at. Next slide. Okay, so I think we're close to an hour and a half, aren't we, Jessica?
Here we're at 6:29.
Okay, so we got 30 seconds to go. It's been really awkward for me, but I hope it's come through to you. Some of the ideas about new approaches, I appreciate that all of you have maintain yourselves here, and I wish I could see and interact with you individually, because that's really my intention. But my intention was to provide a sense of motivation, importance for you. Maybe look at if you're finding frustrations in this area, if you're having some difficulties, think of it as a challenge, think of it as a barrier. You've got lots of support. Your care team is extremely valuable. And I always deal with any new problem whenever I got faxes today. Send me the med list. I'm not deciding anything unless you send me the med list. If it's a patient I don't know very well, I'll still get the med list. I may not take a lot of action, but it's part of my DNA now to get the darn med list. I don't want to talk about problems until I get the med list. Think about something like that whenever you get a call. Anyone have any burning questions? Go ahead. Jasmine? Anyone have something to say?
We're all shy, Mark.
Well, I'm honored that you've asked me back, and I'm very appreciative of this role you're playing. These are going to be our parents. These are going to be our loved ones.
This is going to be us.
I think David's talk about palliation. I mean, it's a word we use, but you need to work in the language of the heart with these people and your staff, and understanding when there's resistance from your staff. Tell me what you think is going to happen. I think that palliative model goes a long way, and I think if we just take off the idea that we need to be meeting guidelines and diagnosing, there isn't a lot there. The evidence is not great that we're doing fantastic results with patients, but I've had a number of patients who turned into much more effective patients in long-term care once a number of horrific medications were stopped. Be careful of the transitions of care from home to nursing home, from hospital or home. It's when the critical things arise. Patients are not treated often very well. Medications are added for symptoms. And once we get the dust settling after a little while in long-term care, it's wonderful to have some conversations. I thank you all for what you're doing, and don't underestimate the value that each one of you can provide. I know the physician sort of has to take the point often, but by having an effective team that understands and can communicate some of those wishes to caregivers, we will all be more successful. So once again, remember, the absolute number of medications is the single most important factor. Any new symptom that comes up could be drug related. And always asking, given I know what this patient in this condition at this time, would I prescribe this drug at this dose now? If you're not sure, hold the pen. Have a look at things, and always go back to the idea that, and the other thing is always have the suspicion. You got to think about that iceberg. There's stuff going on. We have no idea. No one can prove it. But time and time again, reducing medications or eliminating has a positive benefit. And you will be appreciated for your care, and that you brought focus away from the drugs and diagnosis and back to the person and family, and they will appreciate you forever for that. So thank you. Any other final comments on anyone? I wish I could be in person, but hopefully this has fulfilled some needs. Have a look at my slides if you know some details. Let's hope that this encourages you to make some changes. And please write down that commitment statement. I didn't do the research, but the guy said it works. So commit to it. God darn it. Okay. Commit to something that you can write down that means something to you, and hold yourself to it for now. Okay.
Thanks,
We
Mark.
really appreciate you coming today. Thank you so much, Dr. Lawrie. That was
okay. Everyone, get some supper and enjoy yourself, and you're doing a good job. I appreciate it very much. Thank you.
Thank you
Bye-bye.
so much. Have a good night, everyone.
Good night.